All right, well, we'll go ahead and get started. So we're going to wrap up chapter, what is this, 9 today. You have another quiz. You have quiz 3, opens on Sunday, closes on Monday night. I have adjusted the time allowed to 2 hours after a couple of requests. You still not going to have enough time to, if you haven't done the reading, you haven't taken the time to study the material, you are just, you're going to struggle. So I really, for those of you who have had some difficulty with the quiz, maybe not getting the grades you'd like, really, if I would like you to reflect on, have you read the chapter? Have you taken notes out of the chapter? Have you reviewed the slides? Have you been taking notes in class? Have you been coming to class? Because right now I'm looking around the room and I think there's less than half of the class is actually physically here. Nothing magic happens in the, well, if you're not here, you don't know all the magic that's actually happening. I will say that nothing particularly magic happens from my side. What really helps is your mindset by actually physically coming to class. I've seen, with COVID over the last 2 years, I have seen a pronounced correlation between individuals who come to class and their grades, meaning with a positive correlation in terms of coming to class. People who come to class tend to do better than people who say, I'll just watch the video at home. So if you're one of those people who chooses to watch the video at home and you are not doing as well in the class as you would like, I would strongly suggest that you start coming to class. Okay, so exam 3, quiz 3, whatever it is going to be Sunday. It'll cover chapters 7, 8, 9. You'll have 2 hours to do it. I also said at the end of last class that I would give some extra credit. So the extra credit, the first extra credit is worth 5 points. I'll add it onto your exam 1 grade. And it doesn't really matter where I add it because it's just going to get added into your total exam score anyway. And that was to watch the movie, The Sound of Metal, and then apply the anthropological theory of illness and disease. So I'm going to circle back to that in a second. So that's number 1. Number 2 is I'm going to set up a series of small group meetings with some of the folks that you guys wrote your papers about. So the first one is going to be with Eileen Keefe, who's the Chief Nursing Officer at Parkland. I've reached out to Sayuka Salstrom, who a whole bunch of you did, to see if she'd be willing to do a Zoom call. And if you've got somebody else that you did and you'd be like, I really would like to meet the person I wrote my paper on, shoot me a note. I'll probably do at least one more. I'll try to get at least 3. You can do one of those. Okay, so you can't do, and so you can do, in addition to doing the Sound of Metal paper, you can also do one of the 3 or 4 that I set up for extra credit. You can attend more of them if you'd like, but I'm only going to give you extra credit for attending one of them. And I'll let you know as I lock them in, I'll let you know when they're available. So if you're not particularly interested in talking to a chief nurse, I'm lining up a psychologist. So if there's some other people that you'd like to meet, I'll see about. And I can also, I focused on doing them during the common exam time because you shouldn't have a class during that window. But I may look at doing one like in the early evening as well. It'll depend on their availability. So you can do that. And then I'm thinking about something else. I'll probably do like a third thing for another 5 points. So that's a lot of points to add on. It's not enough if you do all of those, it's enough to bump you over probably a half a grade. Okay, so now circling back to the first assignment, because I had a couple of questions about it. I want to clarify. So the anthropological theory of illness and disease. What was an illness versus a disease? Who remembers? Yeah. Right. Good. So illness is a subjective judgment by the individual that there's something wrong with me, that I am not able to perform all of my social roles. Disease, on the other hand, is something that a social authority identifies about you, saying you can't perform all your functions. So, and you could say kind of broadly society, you could also say, technically it should be like a physician says, there's something wrong with you. But you could also kind of, within this kind of, you could broaden the disease side to say, society believes that a person with this particular condition cannot perform all of their social functions, okay? So with the application with the Sound of Metal would be to look at both the illness and disease components and how they operate. And also you might think about, is there a change over time in the character in particular? So, all right. So there's that. Like I said, I'll come up with a couple of more people you can visit with, and then we'll, and there'll probably be a third thing, maybe connected to the next segment. And I have I said I wouldn't say it, but I have a commitment from a former student who's a nursing home administrator. She said she'd dial in next Thursday to our class. She's graduated in 2018, so she's young. She's still young, but she's really proving to be a remarkably talented young administrator with a great career ahead of her. So I thought you might enjoy hearing about her career so far and kind of lead. I mean, they've moved her. She works for Genesis, and they've moved her around even during COVID because she's just so good at what she does. So, we'll next week we'll be talking about long-term care, and she'll dial in for a little bit. Okay, but today we will finish up with our discussion of managed care. So we went through the variations on HMOs, different kinds of HMO, from the most controlled to the kind of from the sense of the most integrated, where the insurance company employs its physicians, probably maybe even owns its own hospitals, to the least kind of integrated, but still an HMO, where the insurance company contracts with a subcontractor who basically builds out the network that the HMO is going to use. So it kind of, and then we have kind of in between. The key thing about managed care that you want to take away is, right, as you move farther into these managed care plans, the more restricted your choices are. But there's a potential cost savings as well. So HMO plans tend to be cheaper. The reason they tend to be cheaper is because you have less choice and you're turning over the management of your care to an insurance company. And this is, not unlike the European style insurance plans, where you have less choice, right? There's a part of the reason why it's cheaper to get healthcare in Europe, right? Part of the reason they spend less is they give their beneficiaries less choice about treatments, about which doctors they want to see, and so forth. Okay. So all that's been around for a while, right? HMOs have been around since the 30s in various forms. What we're seeing today, and I've talked a little bit about value-based contracting, but so we're going to kind of hear it again a little bit, is again, value-based contracting is really kind of is part of that last stage of evolution of our health system, where we're trying to move into health reform. And so the ACA really pushed us towards various approaches to paying for healthcare. So value-based contracting, what organizations do is they contract with an insurance company and they agree to deliver, they agree to a contract that is not just based on fee for service. Now, it's not necessarily perfectly capitated. In this, what we talked about capitation was they would receive, the provider receives a per member per month payment from the insurance company. Value-based contracting is kind of a hybrid between that. So for example, one of the things that we're going to talk about, well, we'll talk about the risk sharing, but one of the things that is common in value-based contracting are quality measures. So your insurance company, Medicare, collects data about quality, things like patient satisfaction. So how many of you guys have gone to your provider and then gotten an email or a letter saying, how satisfied were you with Dr. Smith's care? Yeah, you get right. So they're doing that in part to get better at what they do, but in part because this is probably part of the contract that they have with your insurance company now, is to collect data on your satisfaction. There are other things that you don't see that they're collecting data on, things like readmission rates. So if you go in and get, or your grandmother goes in and gets a hip replacement, does she wind up getting an infection 2 weeks later and have to be readmitted and have, additional surgery to clean out the infection? That's a negative quality indicator. And so the contracts under value-based contracting, common adjustments to the payments that providers get include things like patient satisfaction. So in the contract, they may be on kind of 90% of it may be fee for service, in the sense that, if you go in for a hip replacement, we're going to pay you $20,000. But there are adjustments to the contracts now that recognize things like the actual value that you as a patient put on the care that you're getting. So you would value care more if you didn't have to be readmitted. You'd value care more if you felt like your doctor actually listened to you. And there are measures that you can look at on, you can go to a website called Hospital Compare, and you can see a set of metrics that are collected by Medicare about different hospitals. And you can see how they score for things like, I felt like my doctor listened to me. I felt like the nurses listened to me. I felt like the hospital was quiet at night. Measures like that all get added up, and they adjust the reimbursement that the insurance company pays the provider. So those are some examples of value-based contracting. Now, we have already talked about shared savings and risk sharing. So I'll just rehash that a little bit so you remember. So under value-based contracting, we're doing a lot of risk sharing. And so what we look at is who is covered by who is reliant on the provider. And so we talked about, like, Wentworth Douglas. If you live in Durham, right, or Dover, probably you get your care from Wentworth Douglas or an affiliated Wentworth Douglas provider. And so they would say, okay, the insurance company would say, okay, these people have been getting primary care from your system, so we're going to regard them as reliant. And then we're going to look at how much money they all spent collectively on healthcare. That's their total medical spend for the period. And then the agreement with the Provider is, if last year they spent $100 million, if your reliant patient population spent $100 million in total on healthcare, and you can bring that number down from 100 to 95, we'll share that savings, hence the shared savings contracts. Now there are contracts that have upside risk only, meaning you can only share in the savings, but if something goes badly and instead of the cost of care going down from 100 to 95, it goes up from 100 to 105. Nothing happens to you as a provider. You don't get a bonus, but you don't lose anything. With two-sided risk, you're at risk in both directions. So if you save money, you get to share in the savings. But if the patients spend more, so let's say it goes up to 105, now you're going to lose some of your money that the insurance company would have paid you. So the insurance company withholds some of its payment to you until the end of the period when they do the adjustments, and they then either pay out or they keep whatever they withheld. So those are some examples of value-based contracting. Some of it's based on quality, and some of it is based on managing costs. All right. Accountable care organizations, talked a little bit about these as well. They can be integrated or an integrated system, meaning so for example, Mass General, right? Mass General Brigham is an integrated system. They own physician practices. They own the two big gorillas, Mass General and Brigham, but then they own a whole slew of other hospitals, including Wentworth Douglas, right? They also own a whole bunch of other services and providers, such as ambulatory surgery centers, provider groups, and so forth. And so insurance companies will do these value-based contracts with ACOs. So they'll contract with an ACO. So the idea of an ACO is that they are capable of providing, if not all, at least most of the care that the reliant community, the reliant patient population needs. And so they have enough, they're able to be accountable for the care. And so they are, because they provide most of the care to these patients. So they are able to take on these risk-based contracts on behalf of the patients with the insurers. This was a big innovation, a big change. And so you can have actual integrated systems, like I said, like MGB, or you can have virtual ACOs where the hospitals are working together in a sort of partnership or a joint venture, right, where they're not an integrated system, but they're sharing information about the patient. So here's what's interesting. Medicare ACOs, right, which were created by the ACA. Medicare ACOs, if you're an ACO with a Medicare, an ACO with a Medicare value-based contract, if you're doing one of these risk-sharing contracts with Medicare, what Medicare will do is they will send you the information about all of the patients that they believe are reliant on you. So let's say your grandmother goes to Wentworth Douglas. Wentworth Douglas was, I don't know if they still exist or not, but they were part of a virtual ACO that included Exeter, Concord Hospital, Elliott, and a few others. Kind of spanned almost all of Southern New Hampshire. The ACO, whoever is kind of running the ACO, will receive all of the utilization data about the Medicare beneficiaries who are regarded as reliant on the ACO's providers. So for example, if your grandmother, who's a Medicare beneficiary, gets her care at Wentworth Douglas, the ACO, which used to be located at Concord Hospital, the office, the people who were running the ACO on behalf of all of these other hospitals involved, was located at Concord Hospital. Medicare would send all of your grandmother's utilization information to them. Every time she did anything with the healthcare system and generated a bill, that the ACO headquarters gets that information. So every time she goes to see her primary care doctor, every time she gets admitted, goes to the ED, if she falls down and breaks her leg while she's on vacation and Medicare pays for it, if she went to get her well woman exam, if she, everything. So they have, what they get is all of the payment information and diagnosis information. And so what they can do with all that information now is use analytical tools, right? So AI, machine learning kind of stuff. They can look at the data and they can say, you know what we've seen is people who manage their A1C, right? Who have an A1C of, say, less than, I don't know, nutrition people tell me, what's a healthy A1C? It's a test. Where are my nutrition majors? Yes, ma'am. That sounds about right to me. I'll believe you because you're a nutrition person and I'm not. I know it's somewhere around there, right? So you want to be like, you want to ideally be lower. And what's an A1C measure? It's blood. It's a typical. It's a test you use to figure out if you have diabetes. So an A1C. So you can either get a glucose test, which tells you how much sugar is in your blood right now. So if you've ever gone to get a physical and they say, hey, we want you to fast, right? What they're likely doing is they're testing your blood sugar, your fasting blood sugar, amongst other things. Also, cholesterol you need to be fasting. But what they want to see is kind of what is, when your digestive system is not in the middle of processing food, what is your blood sugar level? So you want to be like, well, I think it's below 100 for glucose, if 123. All right, I'll believe you. You want it lower, not too low. There's a kind of a happy range. Like if you're 0, you're dead. But also if you're too high, you've got diabetes and you're likely going to die too. I'm a hospital administrator. I'm not a clinician. So, do not take any of my statements as medical advice. No, but there's so you're testing. So you test glucose is you're testing right now. What's your blood sugar level, right? And so if you are a diabetic, and I don't mean to make light of that because it's really a challenge to live with. But if you are a diabetic, right? If you have a friend who's a diabetic, they're testing. They'll test throughout the day. They're testing to see if their glucose levels are under control, and they're injecting insulin to help control that level. The A1C, right? So the glucose kind of, if you like ate a big bowl of ice cream, right? And then you went and had your glucose tested, you would have a really high glucose level, right? But 6 hours, 8 hours later, if you didn't eat anything else, your glucose would go back down into normal range, most likely if you're healthy, normal range. What the A1C, so it's changing constantly. So the glucose is not that useful in terms of diagnosing if you have an issue like diabetes. The A1C is measures, and I don't understand the science behind it, but it basically measures kind of your body's long-term management of sugar, so of blood sugar. So you want, I want to say normal is like 2 to 5, something like that, and you want to, and you're in danger if you're above a certain, like 7, 6 point, you said 6.5, I think, right? So 6.5 or higher, then you're medically concerning, but like normal is somewhere in the like 2 to 4 range. But what that does is it kind of gives you like the last 30 days, how did your blood sugar level work? So I'm saying all this because one of the measures that that would get reported, to about your grandmother to the ACO would be all her lab results. And so they'd be sifting through things like lab results to say, we've noticed that people with a high level, high A1C consume more medical resources. Well, why would that be? Well, because they're either diabetic or pre-diabetic. So what we're going to do is we're going to reach out to anybody who has a higher level A1C reported, right? We're going to reach out to them and see if they haven't. Well, first we'll check, are they being followed for concerns about their blood sugar level, right? And then if not, we're going to get them in to get looked at, try to figure out, are they pre-diabetic? Can we get them on a medication? Can we get them to adjust their diet, right? Because you have two types of diabetes, right? You have type 1 diabetes, which is you're born with, and type 2 diabetes is acquired over a life course. Type 1, there's not much you can do about it. It's congenital, you've got it, and you just have to manage it. Type 2, people get it usually later in life typically because they're obese and their body can't handle the amount of sugar that they're consuming. And so you're basically outrunning what your pancreas can process. And so if you can get them to lose weight, change their diet, very often you can kind of eliminate the effects of type 2 diabetes. You can, get them back into a healthy zone. There's medications that can help with that as well. And so that's what you nutrition people will be working on probably quite a bit, in your career is working with, because that can be fixed through behavioral modification. So an ACO would be running through the data that Medicare is providing them about the patients that they're that they are reliant on them. And then the organization would be trying to do things that would help improve the health of the patients. And so if they can improve the health of the patients, it's not purely an altruistic thing. If they can improve the health of the patients, then the assumption is we'll reduce the medical spend. And if we can reduce the medical spend, then we'll share in the savings. Yes. I'm sorry, last part. How are they protecting the patient's information? Yeah, so I mean, that's a great question, right? Because it's a huge amount of private data. So we have the Health Information and Portability Act, HIPAA, you may have heard of, right, is a set of laws that came out, I want to say in the 90s, I can't remember exactly. It's in our book. HIPAA governs all the ways that an organization has to protect medical information about patients. But yes, they're getting a huge download of super private data, right? I mean, there's, I don't really care if you see my cholesterol measures and stuff like that, but I would care if you know that I'm going for mental health care, right? That's kind of private. I don't really want just random people having access to that information. If I have a sexually transmitted disease of some sort, I really want that protected. If I hurt my foot, I don't really care if you know, right? So how do they protect it? They have to encrypt it. They have to keep it, secure. I'm not an IT guy, so I can't tell you how they do it, but they are but if there are huge penalties for organizations if they don't protect it properly. Now that is a great point though, because you haven't consented, right? Your grandmother didn't consent to having the data shared to Concord Hospital and then shared with 5 or 6 other hospitals, right? So, so the law says they can do that though, right? That's part of the ACA. So that's it's a great point about privacy, right? By accepting, I guess it's kind of like terms of service kind of thing, like, like when you go to sign up for a new like Spotify or something like that, it says, you've got like a 20-page terms of service, and you're like, click here to say, yes, you've agreed to the terms of service. And all of you, of course, read, the whole document about your terms of service, right? Every time you do something. No, you just click yes and you move on. And little did you know that they're going to be sharing your data with, everybody and their grandmother. No, but that is a serious question. I don't know how they resolve that. I know that's a discussion's been had, and they are legally allowed to have the access. But and here's another thing, Medicare data is accessible to researchers. So those of you who maybe want to get into research, some sort of research down the line. So if you want to go get your, master's or your PhD in nutrition or something like that, you may want to look at Medicare data, Medicare data about populations, and we can get it. What they do is they remove all the patient identifiers. So like your social security number, your name, your address, all that stuff is taken out, and you'll get reports. If you pull this down, you'll get reports that say, 72-year-old female residing in the 03820 zip code, has the following conditions, so forth. So they try to strip out identifiable data. Not so with an ACO. With an ACO, they're getting your patient identifiable information with the very purpose that they're trying to figure out how can they take care of you better. So there's a trade-off in terms of security and privacy, and that's the justification. Is we're sacrificing your privacy as a Medicare beneficiary so that we can hopefully provide you better care. And one of the things that's interesting is, like, if I as a researcher request that data, if there are small numbers of people that have particular illnesses, like maybe there's only one person or 3 people that have a particular, maybe HIV or something like that, which is more prevalent than you would think. They may not give that data to you because you could conceivably kind of back into, oh, that's Bob. I know that data there. I know that combination of symptoms. That's Bob who lives, 2 blocks from me. So they do have, so when it's a researcher, they'll do things like, if there's a very small population that could conceivably be identified, they'll just knock those out of the sample. But that's not what we're talking about here necessarily. So good point, right, about privacy. There's a lot of privacy concerns in healthcare, and protecting patients' privacy is a really important duty. Even if you are, if you're an HMP major, and you're going to be working in the healthcare system as an administrator, you're going to have access to all kinds of data. And if you're not careful with it, you can wind up going to jail or pay large fines. So it's a serious responsibility. So this is a really interesting thing where these accountable care organizations can either be organizations that are merged together, like I said, like MGB and its whole system. Exeter Hospital just announced that they're going to be trying to go and merge or be acquired by, the Beth Israel Lahey system. So that should be happening over the next year or so. And so they would join the Beth Israel Lahey ACO. And so a lot of these organizations are coming together specifically to do things like share this kind of information. Now, if you think about it, your little old hospital, even a Wentworth Douglas, which is a pretty decent sized community hospital, or an Exeter Hospital, which is a pretty decent sized community hospital, having a group of people with the skill to do this kind of analytic work is very expensive, because these people are smart, and I highly recommend, by the way, we have a master's in health data science in HMP, that after you graduate, if you'd like to earn a whole lot of money, That's a field that is very lucrative. That these folks get trained to, analyze data, find patterns in data, and building out that capability is expensive. And so doing that at a smaller, at a community hospital like a Wentworth Douglas, that's a huge investment for an organization of that size to undertake. So it makes more sense for them to join together with other organizations, form an ACO, whether they are merging together as into one real, one organization, or if they're a virtual organization where they're remaining separate, but they're partnering to pay for this service. That's one of the reasons we're seeing, one of the many reasons we're seeing this continuing wave of consolidation and mergers of healthcare organizations, is because being able to take advantage of things like huge data sets and process them is valuable, but also expensive. So let's talk a little more about mergers and acquisitions. So we've talked a little bit about consolidation in the last chapter. So since 2006, this is the number of mergers that have been happening with hospitals. So we know that there's, some 5,200 hospitals in the country. So each year, this is how many hospitals are joining together to form new or becoming parts of an existing system or forming new systems. So you can see that, there was a fairly steady pace of mergers, and then it really picks up as it became clear that the ACA was going to pass, right? And the ACA went into effect in 2014, and so you can kind of see. So leading up to the ACA, that was a long process, a couple of years. But what organizations can basically see the writing on the wall that, hey, this is the direction we're going. We're going to need to be able to achieve economies of scale, which we talked about, I don't know if last time or last week, but economies of scale where we can share expensive overhead things like having an analytics cell, right? If we join together as one big organization, we can hire one analytics cell to look at our data, and as opposed to trying to hire our own and remain independent. So what we've seen is this steady pace of consolidation. So I showed you when we talked about the inpatient care, I was showing you the hospitals and talking about how, when I first got here 7 years ago, most of the hospitals in New Hampshire were independent facilities. Today, most of the hospitals are part of a system. There's only a couple left that are not actually already part of a system. So a lot of pressure to continue to merge. And we've talked about some of the reasons. So this was, one that happened relatively recently, where we had a merger of Elliott Hospital and Southern New Hampshire Health, and they got approved. This is like back in 18, so they merged. So Elliott's in Manchester, Southern New Hampshire is in Nashua, and the state attorney general's office said these two can affiliate. So here's a funny thing. Hospitals like to use the phrase affiliation rather than merger or acquisition. And I think that's because it sounds friendlier and nicer. Like, wouldn't you like to affiliate with me? That's like, we're going to, hold hands, talk nicely, as opposed to I'm going to acquire you. Sounds like I'm the Borg out of Star Trek and I'm just going to swallow you up. In reality, that's in fact what happens, is they swallow you up. So we'll talk. So mergers and acquisitions are two different kinds. They're two different things that result in kind of the same thing. So a merger is when two organizations come together, they create a third organization, and then they basically dissolve the two existing organizations and merge into one new organization. An acquisition is where the acquiring organization takes over the second organization, dissolves the second organization as an independent entity, and that second organization ceases to exist and becomes part of the acquiring organization. So with the Elliott and Southern New Hampshire, they created a third entity called Solution Health, and the two hospitals are now owned by Solution Health. With the Wentworth Douglas acquisition, which they also called an affiliation, but with the Wentworth Douglas acquisition, MGB acquires Wentworth Douglas. Wentworth Douglas ceases to exist as an independent corporation and becomes part of MGB. MGB continues to exist. Wentworth Douglas ceases to exist. It's, you know, it's not going anywhere, but it ceases to exist as an independent entity and just rolls up under MGB. So that's the difference when somebody says mergers and acquisitions. A merger, two companies create a third company, and then they both become part of that third company. And the two original companies dissolve. An acquisition, the acquiring company takes over the second company. The second company ceases to exist as an independent entity and becomes part of the acquiring company. So this was an interesting move, you know, and one of many that are happening, right? We talked about Catholic Medical Center. I couldn't remember the one in Wolfboro. It's Huggins Hospital the other day when I was talking about it. So like Catholic Medical Center acquired Monadnock and didn't acquire. They created a Granite Health. And so they sort of did a merger. But I mean, you're talking about Catholic Medical Center is the second largest hospital in the state, and then two very small critical access hospitals, Monadnock and Huggins. So, you know, they all became part of Granite Health. And now, and then we have Dartmouth Hitchcock acquired Cheshire Medical Center. And I want to say Alice Peck Day, which is a small critical access hospital up near Lebanon. And now Granite Health, the parent organization for Catholic, Monadnock and Huggins, are looking to merge with Dartmouth Hitchcock and create kind of a super system in New Hampshire. So a lot of this happening in the state. So some examples, North Country Healthcare, Androscoggin Valley Hospital up in Berlin that I've talked about before, merged with Upper Connecticut and Weeks. Initially, Littleton General was in there as well, and then they broke out and went back on their own. So Littleton General in Littleton is one of the few standalone hospitals still, but I can't imagine that they'll last too much longer. Granite One Health in 2017, that's the Catholic Medical Center, Huggins and Monadnock. 2018, Wentworth got acquired by Mass Gen. Solution Health, we were just talking about, Elliott in Southern New Hampshire. 2020, Frisbee is acquired by HCA, kind of becomes part of the HCA family in New Hampshire. Parkland Medical Center in Derry, Frisbee in Rochester, and Portsmouth Regional in Portsmouth, right? Now in 2020, Granite One announces an intent to merge with Dartmouth Hitchcock. That's still getting batted around. I think it's been slowed down a little bit by COVID, but I think it'll eventually go through. And it has a lot of political support, because the idea is, instead of, if you live in Concord, it's not much harder to go to Boston than it is to go up to Lebanon, right? So if you're in Concord or Manchester area, right, it's pretty much, you know, 6 of one, half dozen of another to go which direction. Well, if Catholic Medical Center is part of Dartmouth Hitchcock and they're more integrated, they could share, for example, they could share an electronic health record, right? So if you are a Granite One patient and you're getting seen at Huggins and they're like, you know what, you're having a, Huggins is a small critical access hospital. So what we talked about is that's kind of just that secondary level of care, right? So if you've got something more complicated, maybe you're having a stroke, or maybe one of your family members is, older family members is having a stroke, they're going to refer you to Catholic Medical Center, which has an excellent vascular care program. So they'll refer you over. And the beautiful thing is if you're coming out of Huggins and going to Catholic, because they're all on the same health record, whatever was done to you at Huggins is already in the computer system. And when you arrive at Catholic Medical Center, they don't have to send a pack of paper with you saying, this is what we did, right? When you show up, they just pull your name up and bloop, bloop, there you are with all your procedures and all your medical history. So that's a really nice thing. And then if this merger goes through with Catholic, or I should say with Granite One and with Dartmouth, they'd also kind of eventually integrate their medical record system so that if you needed that tertiary or quaternary care, and if you couldn't get your care that you needed at Catholic, they could then refer you to Dartmouth to get that, what they call the quaternary care, the highest level of care. And again, put you on a ambulance and drive you up to Lebanon if you're stable, fly you up to Lebanon if you're not, right? And when you showed up, because you're a patient in this system, all your information is already in this, in their medical record systems, which makes that transition very smooth and very nice. It's also nice if, for example, you get hurt after hours and you go to a Wentworth Douglas. If you go to a Wentworth Douglas urgent care center, right, and you're part of the Wentworth, and your provider is part of the Wentworth Douglas system, when you get seen at urgent care on a Saturday night, your information is in your provider's system, so that when you go in the next time to see your regular primary care doctor, she'll pull up your medical record and say, oh, I see you got seen at urgent care 3 weeks ago. Are you okay? And everything good and everything, maybe even would follow up with you. So that's a nice thing about these medical record systems. And if you're, because Wentworth Douglas is part of the MGB system, if you get care anywhere in the MGB system, it all feeds back into the, you're a known entity within the MGB system. So that's a beautiful thing. The thing about, the reason I'm talking about this is again, we talked a little bit about economies of scale. So building a medical record system is incredibly expensive, right? It requires, we're talking millions of dollars to just put one in at a place like Wentworth Douglas, never mind, at a system level, like tens of millions of dollars. It's not like, is a significant investment. And part of the investment is in the maintenance of the system, right? And so the nice thing about a medical record system is it yields to economies of scale. And what does that mean? Well, you have a high initial investment. It costs you a lot to install the system, but to add one more provider to your system once you have the main system installed is relatively inexpensive. So in economics, we refer to that as the marginal cost, which is the cost of adding one more thing, right, is relatively low. So you have a big upfront fixed investment. So maybe you have to spend $50 million to install the system. But adding one, if you get a new provider, adding that provider, or adding more patients to your system is very inexpensive. And so if you're going to spend $50 million to, build a electronic health record system that covers 3 hospitals, adding a 4th hospital is relatively inexpensive. Whereas if the hospital tried to, so if Wentworth Douglas was independent of MGB, they would have to spend maybe 30 million. But if all they're going to do is add on to MGB's existing health record, it might be 10 million, right? So there's it by becoming, what we can do is spread that very large fixed cost over a lot of entities. And so that's one example of one of the economies of scale of mergers and acquisitions. So you can, the logic of that is you can spread fixed costs. So I just talked about this a little, got a little ahead of this of the slides. Like I said, healthcare organizations like to refer to them as affiliations because mergers and acquisitions sounds very like Wall Street and aggressive, right? And so we're all friendly, we're all holding hands and singing songs together when we do affiliations, whereas mergers and acquisitions sounds very much all about the money. And let's not kid ourselves. We've talked a lot about money in this class, and money makes the healthcare world go round. But when you hear a healthcare organization talking about affiliation, it can mean mergers and acquisitions. It can also mean alliances. And so an alliance, so it gets really murky, which is why it's annoying that the industry uses the word affiliation, because it can mean a whole bunch of different things. It can mean that we're going through either a merger or an acquisition, or it could mean that we are agreeing to play nicely together. So creating an alliance. And so what does that mean? Well, Exeter Hospital had an alliance with MGB prior to their decision to go with Beth Israel Lahey and be acquired by Beth Israel Lahey. And so I haven't talked to the leadership over there about this lately, but I'm presuming that they have an alliance with MGB to provide oncology services at Exeter Hospital. So if you go get your oncology services at Exeter Hospital, the physician that takes care of you is actually an MGB physician. So Exeter provides the space, provides the nursing care, and then MGB provides, well, it's actually Mass General. So Mass General provides the physician and the physician leadership. So the medical director of the oncology service at Exeter Hospital is a Mass General doctor. He's a nice guy, I know. So that's an example where Exeter Hospital has an arrangement, an affiliation, and that's I think that's a better use of the word affiliation than to refer to a merger. They have this, it's more in mergers and acquisitions speak, that's more of an alliance where they have an agreement that they're going to share a resource. And the benefit to Exeter is they get a highly trained physician that they don't have to be responsible for paying. The benefit to MGB is, and we'll talk about this in a minute in more detail, the benefit to MGB is if this MGB physician says, you have a cancer that I can't effectively care for you here at Exeter Hospital, I want to admit you to Mass General, right? So the benefit to Mass General of this arrangement is they kind of get a flow of complex patients out of Exeter. Now, if it had been a Lahey doctor, which it probably will be in the future, if it had been a Lahey doctor, they would have said the Lahey doctor would not refer you to MGB, they'd refer you to Lahey, right? And so the alliance arrangement, the benefit to Exeter is they get to borrow a highly trained physician with a lot of credibility because he comes with the Mass General brand, right? So you're like, I'm going to Exeter, I'm terrified. Like that's the scariest word in the English language, right? Is you have cancer. I remember my wife and I, we had just had our first baby. She was maybe like 9 months old, and my wife my wife's primary care provider thought she might have hypothyroidism, which is when the thyroid stops working. It's a no big deal disease. It's pretty common. If you have it, you basically take one pill a day and you're fine. So they were in the process of diagnosing her with hypothyroidism, and so they referred us to. We were living in Denver at the time. I was still in the Army. We were living in Denver at the time, and they referred us to the medical center in Denver for her to get a radiology workup. Well, the medical center in Denver is a teaching hospital, right? So she gets sent in to go to see a radiologist to get an imaging study of her thyroid, and the physicians provide so if you ever get care in a teaching hospital, it is likely you will have, have you experienced what I'm going to, yeah. All right. So if you ever get care in a teaching hospital, what happens is if the attending shows up to like do a procedure, he or she will be followed by a gaggle of residents. So it's like the mama duck followed by like, a whole bunch of little ducks behind them. So my wife, they went and they did the imaging study. And this clown, this doctor, who's in my opinion, is a bit of a jackass, is talking to all his residents and basically ignoring my wife. And like, see this, blah, blah, blah. And my wife is basically just laying on the bed, like, I don't know what's going on. And so finally he turns to her and he says, well, do you have any questions? She's like, well, what is it? What happened? And he's like, well, it's probably not cancer. And all she heard was cancer, right? It's like, and she comes out, so, and then he's like, any other questions? And she's like, no. And so, the gaggle leaves the room, and she, like, the nurse says, put on your clothes and go back out. She comes out to the waiting room. I'm sitting there with our 9-month-old daughter in a basket, and she just starts crying because she's like, I have cancer. Which, so hence I never met that doctor, but man, I just like to kick him in the ass. And this was like, 5 o'clock on a Friday night. And, we're pulling out of the, so, we got the brand new baby and my wife's got cancer, and I'm like, none of which was true, right? But it was just his terrible bedside manner left us both thinking, and I'm like driving through, rush hour traffic in Denver thinking, oh my God, my wife's going to die. I'm going to have to take care of this little baby by myself. What am I going to do? What am I going to do? And it's, this is 1997. So we don't have cell phones, right? And no internet. Internet maybe, but it wasn't like you had Uncle Google that you could like look up thyroid stuff. That was, a decade away. Tried to call my dad. I told you my dad is a pathologist, so he knows this stuff. Well, he's gone for the weekend. No cell phone, can't reach him. Her doctor's gone because it's Friday night. So we're like the whole weekend. We're like, oh my God, what are we gonna do? What are we gonna do? Then she like gets a hold of her primary care provider on Monday. And the provider, and she says, I have cancer. And she's like, what are you talking about? And she's like, I got the readout. She says, you have you have a whatever, yeah, you have hypothyroidism, but you don't have cancer. And she's like, well, the doctor said I had cancer or something. So it was terrible care, right? Terrible standard of care. But why was I telling you that story other than it's just like a little bit of therapy for me? So anyway, so cancer doctors, right? So you have this cancer doctor out of Mass General who wouldn't do that sort of nonsense. So you've got a high quality of care, and now with Exeter realigning with or aligning with and being acquired by Beth Israel Lahey, that system will probably be replaced. All right, so I want to talk about types of integrations and types of mergers. So mergers happen for a couple of reasons, and they are forms of mergers or acquisitions. They are forms of integration. And so one is not like these can, a merger can either be a horizontal or a vertical integration. An acquisition can either be a horizontal or vertical integration. So it's kind of like a 2x2, if you will, right? So a horizontal integration is when two organizations of similar types get together. And they do so for the purpose of usually of accomplishing some sort of economy of scale. So the example that I used about a medical record system, right, an electronic health record, is a great example of the type of service that yields a lot of economies of scale. So Elliott and Southern New Hampshire getting together, what they can do is they can now share one fixed investment in their health record system. And so they might spend $50 million for both systems to have a electronic health record, as opposed to say, 35 million for each of them to have one. So they're able to cut their total spend from 70 to 50 by coming together. There's a whole lot of other things that can be done like that, usually on the administrative side. Like if you're one system, maybe you only need one CEO that can oversee both, and you can have a chief operating officer at either facility. That's a common thing to do, right? That saves a whole bunch of money. You can consolidate things like HR and finance. There are some things in HR and finance that have a lot of economies of scale, like running payroll. Running payroll for 1,000 people or running payroll for 5,000 people probably doesn't take a whole lot more effort, right? You might have one FTE, one full-time equivalent, one person running payroll for 1,000 people, but to run payroll for 5,000 people may only take 2 FTEs, right? Might only take 2 people to run. So if you can consolidate, maybe you can cut some of your payroll people, right? So that's a typically, and you don't really care where your check comes from anyway, because it's going directly into your bank accounts. It's not like it matters whether your pay is being processed in Nashua or it's being processed in Manchester. As long as you get it, you don't care, right? A lot of HR stuff is similar to that. There's a whole bunch of back office HR things, like negotiating for a health plan for your system, right? Your HR department, if you're a larger HR organization, there are people who spend their whole day worrying about benefit plans. What kind of 401k are we going to offer people? What kind of health insurance? What kind of life insurance? What kind of disability? There are people that that's their whole job, right? At a larger organization. That doesn't have to be in either, so with a consolidation like Solution Health with Elliott and Southern New Hampshire, it doesn't really matter if that person sits in Manchester or sits in Nashua, right? They can still get the job done. So if you had one benefits person at the Elliott and one at Southern New Hampshire, chances are you can get rid of one of them, right? And just have one for the whole system. So that's another example of an economy of scale, right? So that one person can do it for the whole system. It doesn't require a whole lot of extra people. Billing is another great example of something that has an economy of scale. So when billing is done, it doesn't matter where it's done. So, and in fact, some places we outsource it and just give it to a third-party provider. But if you're going to get a bill in the mail as a patient, does it really matter to you whether it was postmarked out of Manchester or postmarked out of Nashua? No, not really. And the billing people, they can be consolidated in one place or another. A lot of the billing is done by computer anyway, so it doesn't necessarily require a human being to review it. So that's another example of consolidation that can, where you can probably eliminate FTEs. And remember what we talked about, healthcare organizations, more than half of the cost of running a healthcare organization is usually people, right? And the cost of people's salaries. So horizontal integration is almost always about economies of scale, about cutting away redundancies, right? And focusing. The other thing it's important for is increasing the negotiating power of the organizations with insurance companies. If we have more covered lives under our two organizations, if we bring them together, we are bigger when we go to negotiate with a healthcare organization, with a health insurance organization. And so we can negotiate better contracts. Likewise, we can also, I've talked about this before, we can also negotiate better prices with our suppliers. So if we're buying Band-Aids and we're going to buy 2 hospitals worth of Band-Aids, we can usually negotiate a lower price than if one hospital is buying by themselves. Okay, so that's horizontal integration. We're taking kind of 2 very similar organizations and bringing them together. The primary goal is economies of scale. Vertical integration is different. Vertical integration is taking 2 organizations that are at different points in the value chain and integrating them together. So using a non-healthcare example for a minute, because I think it's easier to understand. Imagine you are Ford Motor Company and you have factories that produce cars. Well, what goes into cars? Well, one of the things that goes into cars, as we're building it, there's a lot of stuff, but you've got to put tires on the cars, right? Ford doesn't make tires, it makes cars. So it buys its tires from, say, I don't know, Michelin. So Michelin is farther back in the value chain from Ford. So Ford is kind of the final assembler. Really what their factories do is they put together the car, but they're buying parts from other organizations. So Michelin is farther back in the value chain. They produce tires, which they sell to Ford, and then Ford builds the car to include the tires. Does that make sense? So backward integration is when someone farther down the value chain reaches backwards and acquires one of their suppliers. So imagine Ford buying Michelin Tire Company. Now they own the company that supplies them with tires, right? And so when in a world where Ford doesn't own Michelin, and they don't, I'm just making those up for now. In a world where Ford doesn't own Michelin, if Ford places an order with Michelin, they could say, well, GM just placed a really big order and we're going to supply them first. Then when we're done with them, we'll get to you. That might be annoying to Ford. So they say, screw it, I'm just going to buy you. And whenever I call you and say, I want tires, you're going to send them to me, and the hell with GM, right? And they can wait seconds. So that's kind of the idea behind backwards integration, and this is a form of vertical integration because we're going up and down the value chain rather than across horizontally, right? So Ford Motor Company, car manufacturer, is different than Michelin, a tire manufacturer. So companies will sometimes go backward and buy companies behind them in the value chain, or sometimes companies farther back in the value chain will buy companies forward in the value chain. So Michelin acquired Ford, that would also be a vertical integration. It'd just be a different direction along the value chain. So in healthcare, vertical integration, we have to think about a little differently. I talked about a minute ago about Mass General providing a physician to work at Exeter Hospital. This was an alliance, not a merger, but it's kind of a vertical integration in the sense that the benefit that Wentworth Douglas gets is they get access to MGB's physician, and MGB really wants, what MGB really wants is that physician that's placed at at Exeter to refer complex patients to MGB. So the benefit kind of flows both ways. A better example in this case is MGB acquires Wentworth Douglas. Same process now though. So now they are actually the same system. So this is in fact Wentworth Douglas is a smaller and different kind of organization than MGB is. MGB offers, you can get if you lived in Boston, you can get your primary care from Mass General. Like you can get your primary care from a Mass General doctor. But MGB is a teaching hospital. And for MGB to be successful as a teaching hospital, it needs lots of complex cases because those little residents that follow around the attending need to be able to do complicated procedures in order to get residency qualified. Right? So what MGB needs is a continuous flow of complex cases. Now, MGB sitting by itself isn't going to be able to guarantee and refer like it's got its own primary care doctors, but they're not enough of a resource to make sure that MGB gets enough complex cases. MGB could try to, and had historically, had a relationship with other hospitals and other physicians around the Boston area. Everybody knows MGB is a really good facility. So if you as a physician identify, hey, my patient is a really complicated case, I can't send them to Waltham General or to Newton Wellesley, they probably need a higher level of care. They need to go to MGB. I would have sent that to them, but I would have had choices. I could have also sent them to Leahy. I could have also sent them to BI. I could have also sent them to someplace else. So by MGB acquiring Newton Wellesley, by acquiring places like Wentworth Douglas, I mean, the MGB system is huge now. What they do is it's like acquiring Michelin, right? They want, what they do is with this vertical integration is it doesn't force Wentworth, like Wentworth, a provider at Wentworth Douglas can't make you go to MGB. They can just kind of strongly suggest that I want you to go there. And if your doctor says, I really want you to go to MGB, you're not gonna be like, no, I'm gonna go to Dartmouth most of the time, right? But if you have if Wentworth Douglas is owned by MGB, you're already in an MGB system. And so they're gonna, the natural flow is to send all the complex cases to Mass General or to Brigham, right? And so that's the benefit of vertically integrating between MGB and Wentworth Douglas, is Wentworth Douglas gets access to MGB specialists, and MGB is enormous, and so they get to take advantage of MGB's financial strength, and then Wentworth Douglas refers most of its complex patients to MGB, which feeds the teaching mission at MGB. MGB doesn't want more primary care. They don't want more secondary care. What they want is everybody that needs a heart transplant and everybody that needs, some sort of highly complex care. That's what they want. So when MGB buys a community hospital, it's vertical integration, because they're basically buying their suppliers, right? The supply of patients flows from the community hospital system into the teaching hospital. So example here. So last idea here though is, all this sounds great. Here's the thing. There's a lot of evidence that horizontal mergers tend to raise prices. Why do they raise prices? Well, it used to be that Southern New Hampshire and Elliott, to some degree, I mean, they're a fair distance apart, but to some degree, competed with each other. Now they're one organization. They're not competing with each other anymore. So you can't like try to play Elliott off of, not that you generally would, but they would do it to themselves. You can't like say, well, how much would it cost to get a, hip replacement at Elliott? Oh, it's going to be 20,000. Well, hey, Southern New Hampshire, Elliott says it's going to be 20,000 to get a hip replacement. How much will you do it for? It used to be, they might say, well, I'll do it for 19. You said they'll do it for 20, I'll do it for 19. Okay, now we start driving down the costs. Now, if you show up at Elliott and they say, well, it's a hip replacement's 20,000, and you call up Southern New Hampshire, and you're like, Elliott says they'll do a hip replacement for 20,000. How much will you do it for? 20,000, because we're the same entity, right? And so there's less competition, and so prices tend to rise when you see horizontal mergers. So there's this idea of antitrust. Antitrust is a broad field of law that looks at anti-competitive behavior. So when organizations get really big and they become a monopoly and there aren't many competitors, you wind up with high levels of market concentration. When there's high levels of market concentration, you don't get much competition and prices tend to rise. So examples include things like Microsoft, right? Used to be that everybody thought Microsoft was a monopoly. And they still kind of are. I mean, most of us are probably running Office 360 on our computers, but you do have options, right? You could use Google Sheets. Probably a lot of you use the Google Suite now, yes? I like it. I grew up on Microsoft, but I actually really like using the Google Suite. I do most of my writing on Google Docs, and then I transfer it over to Microsoft. So we have measures of market competition, market concentration. So in New Hampshire, we used to have a relatively fragmented market. Almost everybody was an independent hospital, for example. Today, almost everybody is part of a system, and it's probably going to get more and more so, right? Like the example being the merger between between Granite One, the Catholic Medical Center system, and Dartmouth Hitchcock. You're taking two systems and merging them together. I would put my money on we'll have maybe 2 or 3 systems in New Hampshire 10 years from now, right? I would say there'll be like a Dartmouth-based system, well, maybe 4. It looks like, there'll be a Dartmouth-based system. There'll be HCA, and it's kind of one-offs. There'll be, Mass General reaching up and Leahy reaching up. So maybe 4 within the next couple of years. I think everybody will go with one of them eventually. They can then start colluding on prices, right? And this is called anti-competitive behavior, where the reason we're getting together is so that we can raise prices. That's anti-competitive. Now, there are a couple of levels of review for any time an organization wants to merge. They have to be looked at by both the Federal Trade Commission, the FTC, and the appropriate state attorney general. The state attorney general nixed, the New Hampshire state attorney general nixed Exeter wanting to merge with Wentworth Douglas and then kind of become part of the MGB system. So the state attorney general said no to that, but they did authorize, for example, the Elliott Southern New Hampshire merger. All right. So there are levels of evaluation, and the goal of the FTC and the state attorney general in this case is to make sure that consumers like us, consumers of healthcare like us, don't get taken advantage of by healthcare organizations merging together and then just jacking up their price because they're monopolists, meaning they're the only provider that you can access. All right, so that finishes chapter 9. One other comment. So you've got the exam opens on Sunday at noon, runs till Monday night at midnight. I also moved back the health insurance to sometime next week because I realized it was due the same day as the exam. And I try not to overload you guys. All right, let me know if you have any questions.